Welcome to those of you who are joining this webinar that is being put on by the Francois Baclesse Cyclhad and the University of Florida Proton Therapy Institute. I am Nancy Mendenhall from the University of Florida, and it's my pleasure to welcome you today to this very interesting presentation on the role of particle therapy in various presentations of skin cancer. We are delighted today to have three outstanding speakers: Dr. Curtis Bryant from the University of Florida Health Proton Therapy Institute, Dr. Stefan Dinu, head of the Proton Therapy Department at Francois Baclesse and Cyclhad, and Dr. Dorothee Lebhertz, medical physics from Baclesse and Cyclhad. All of our speakers have no conflicts of interest. I want to make sure you're aware that this is accredited through the University of Florida for 1 CME hour of credit. And we're grateful to the promotional efforts from PTCOG-NA, and the National Association for Proton Therapy. And I would also like to acknowledge the excellent efforts of Dr. Clementine Safar to organize this webinar. I would now like to mention that there will be a question and answer session, but it will be at the end after all speakers have completed their presentations. We'll ask you to put your questions in the chat section, and the speakers will answer as the questions arise. I'd now like to turn the presentation over to Dr. Curtis Bryant. Thank you.
This is Dr. Curtis Bryant. The subject of this talk is proton therapy and the management of locally advanced non-melanoma skin cancers of the head and neck. One of the more common presentations for us for patients in need of proton therapy are patients with clinical perineural invasion, a locally advanced type of non-melanoma skin cancer where tumor cells are infiltrating the perineural space within one of the 3 layers of the peripheral nerve sheath of the head and neck. These patients can often have proximal spread of the nerve invasion along the motor or sensory nerve to the base of skull, the ganglion, or all the way to the brainstem. Oftentimes, the area of tumor infiltration is visible on cross-sectional imaging, and the patient is often symptomatic from the invasion. This is a relatively rare presentation of non-melanoma skin cancer, making up 1 to 2% of all cases in the US. And many times, because of the depth and the proximal invasion close to the base of skull, these tumors are not resectable, and that's why they are often referred for definitive radiation and proton therapy. This is a patient here on the right with an ulcerated lesion involving the left cheek. And on his MRI, you can see that he has extensive subcutaneous involvement as well, the left cheek of this primary tumor. And more superiorly, you can see the patient had clinical perineural invasion of V2 on the left through foramen rotundum into the left cavernous sinus. The most common presentation of patients with clinical perineural invasion usually depend on the nerve that's involved. And the 2 most common nerves involved are the facial nerve and trigeminal nerves. For patients with trigeminal nerve involvement, usually they have numbness, tingling, and formication of the skin directly beneath the tumor invasion. For patients with facial nerve involvement, usually they have facial weakness or asymmetry as the most common presentation. These tumors most often involve the midface, the cheek, the ear, or the scalp. And most patients with clinical perineural invasion either have recurrent disease or poorly differentiated tumors at the time of diagnosis. Again, these tumors are often referred for radiation because surgical resection may not be adequate due to the proximity of these tumors to major nerves and vessels. A gross total resection may not be possible, which leads us to step in and provide therapy. In order to treat these tumors, you have to have understanding of the basic anatomy of the major nerves within the head and neck and face. And so this is the trigeminal nerve anatomy. It emerges from the brainstem, from the pons specifically. And as it enters the Meckel's cave, it forms the trigeminal ganglion. And from there, it branches into V1, V2, and V3. V1, also known as the ophthalmic nerve, provides sensation to the forehead and the central nose. V2 provides sensation to the cheek, and V3 provides sensation to the preauricular area, the jawline, the chin, and the upper ear. The facial nerve also has sensory and motor roots, and they emerge from the pontomedullary junction. And from there, they enter the internal auditory canal, and the motor portions and motor nerve roots, they they exit through the stylomastoforamen and then enter the parotid, where they branch into 5 major branches. These provide motor innervation of the face, and those 5 branches include the temporal branches, as you can see here, zygomatic buccal branches, the marginal mandibular branches innervating the lower part of the face and chin, and the cervical branches innervating the platysma. Importantly, there is zonal classification of the proximity and the proximal spread of tumor along these major nerves. There are 3 major zones: zone 1, zone 2, and zone 3. And whether the nerve is involved in each of these zones has an impact on the overall prognosis. For example, for a patient with a skin tumor with clinical perineural invasion of the distal part of V1, distal to the superior orbital fissure, these patients have a better prognosis than if their tumor reached the trigeminal ganglion, for example, for zone 2, or if they had zone 3 invasion all the way from the trigeminal ganglion to the brainstem. A publication in head and neck surgery in 2011 showed that patients with different levels of invasion, more proximal, in this case, based on this zonal anatomy, they had worse survival. And so for patients with zone 1 invasion, their 5-year survival was 85%, zone 2, 64%, and zone 3, 20%, when treated with traditional treatments, including surgery and postoperative X-ray radiation. So why proton therapy? Well, we think we might be able to improve outcomes, especially for patients with zone 2 and zone 3 levels of invasion. This is a publication from Dr. Holtzman in 2020, who had a group of patients with non-melanoma skin cancers with clinical perineural invasion. In particular, this patient here had a tumor involving the left cheek with invasion of V2 all the way to the cavernous sinus. A comparison plan between pencil beam scanning proton therapy and VMAT was made. And the patient, the treatment plan was set to deliver 72 gray, delivered at 1.2 per fraction using BID fractionation. The table here shows the dosimetric comparison plan between PBS and VMAT. And as you can see, the pencil beam scanning plan reduced the absolute dose of radiation to the brainstem to a volume of 0.1 cc from 62 gray with VMAT down to 53 with PBS. The maximum absolute dose was reduced from 66 gray to 61. The dose to 0.1 cc at the brainstem surface was reduced from 62 to 53, and to the brainstem core was reduced from 55 to 42. So substantial reductions to the brainstem in this patient with a very proximal invasion of their non-melanoma skin cancer along V2. Importantly, when trying to meet these target coverage metrics for the PTV, the VMAT plan wasn't able to deliver a plan that we consider adequate. These doses exceeded our organ at-risk tolerances, and we would not have delivered this plan with VMAT, but we were able to deliver this with PBS. We have published our early results of proton therapy in the management of this condition. This was a prospective outcome tracking protocol that featured patients with non-melanoma skin cancers with clinical perineural invasion treated between 2008 and 2017. These patients were treated with proton therapy with or without surgery, and the median dose of protons was 72.2 CGE. All of these patients received elective nodal radiation ipsilaterally, and we had a median follow-up of 3.4 years. As you can see in our table 1, the majority of these patients had squamous cell carcinomas, so 88% squamous cell as opposed to basal cell or other poorly differentiated carcinomas. The majority of these patients had recurrent disease after initial resection, 69%. These patients were split evenly between those with more distal perineural invasion to those tumors that reached the skull base, about 30%, to those patients with true intracranial involvement, to the trigeminal ganglion in many cases, about 35% of cases. Once again, these patients were treated to high dose, 72.2 was a median dose, and most patients were treated with twice daily fractionation. Many of these patients were treated with twice daily fractionation because of a series of papers that have shown that twice daily radiation may reduce the risk for optic neuropathy after high dose skull base radiation. Many of these patients had only biopsies. They were not treated with gross total resections or subtotal resections even. 73% of patients had biopsy only before delivery of radiation, and 62% of these patients were treated with concurrent chemotherapy. As you can see, our survival analysis is provided here. Specifically on the left, we're looking at disease-specific survival, cost-specific survival, and overall survival. At 3 years, cost-specific survival was 73%, disease-free survival 60%, and overall survival 59%. When looking at local control, 81% at 3 years, local regional control was 65%, and distant freedom from distant metastasis was 96%. Most of these patients don't fail distantly. They fail either regionally or locally. Importantly, what we found is that with protons, the 3-year cost-specific survival by zone of invasion was 88% for patients with zone 2 and zone 3 levels of invasion. And so compared to the previous publication where you saw those numbers drop to 64 and 20%, this was an improvement to historical controls. We did see a reduction in the potential for cost-specific survival for patients with more distal disease, though, and I'll talk about that in the next slide. So it turned out one of the most common reasons for failure among this group of patients was invasion of adjacent nerves, oftentimes connecting to the same ganglion. And so we found that regional perineural invasion alone accounted for 25% of our failures. When combined with local and regional failures, another 2 cases were found featuring regional nerve failure as part of the pattern of failure. And so from this, we have had a change in our treatment recommendations where we now electively cover nerves that connect to the same ganglion in hopes of preventing these regional nerve failures. Usually we cover that in our CTV standard risk volumes to a moderate dose of radiation. Our grade 3 toxicities are listed here. We had 3 toxicities in 7 patients, including 2 patients with keratitis, 3 with hearing loss, 1 with an orbital infection, 1 with soft tissue necrosis, 2 with brain necrosis, and 1 patient with a subdural hematoma. We didn't have any grade 4 toxicities, these are all grade 3. That we did not have any case of optic nerve neuropathy or retinopathy, which is surprising given the doses that we gave to the ipsilateral optic nerve many times that exceeded 60 gray in almost all of these patients. And so for our conclusions for proton therapy and the management of patients with non-melanoma skin cancers with clinical perineal invasion, we think that proton therapy may improve outcomes for patients with zone 2 and zone 3 levels of invasion. Again, we electively cover nerves connecting to the same ganglion within our CTB standard risk. We consider concurrent chemotherapy a potential way of improving local control for these patients. And we favor pencil beam scanning over passive scattering because of its improved conformality. We think we might be able to lower the risk for some of those grade 3 complications that we have found in our earlier publication. So how are we treating patients today? Well, we simulate patients with an oculoplast mask and neck cushion and basal skull frame to reduce the air gap between our gantry head and the target. We mark all areas of gross disease on the skin using wire before our CT simulation. And we perform an MR simulation for these patients, or if that's not available, we recommend fusing a diagnostic MRI to the CT simulation in effort of contouring these cases as accurately as possible. As far as PBS planning, we use multi-field optimization with 3 to 5 fields. We try not to have more than 1 field stopping in the same region of a given critical organ, in particular the brainstem. We use Monte Carlo algorithms for PBS planning, robust optimization, and LAT optimization as well recently. How do we define our targets and organs at risk? Well, our gross disease is defined as that seen on the cross-sectional imaging, as we mentioned before, usually an MRI fused with our CT sim. We also contour any and wire any areas as seen as gross disease on the skin and include that as the GTV. Our high-risk CTV usually includes a GTV plus a 5 millimeter boundary edited for anatomic boundaries. And then we consider 1 centimeter margin on the surface of the skin for any tumors visible on the surface of the skin. The standard risk CTV includes the proximal nerve stations along the nerve that's involved. And so if only the distal ophthalmic nerve is involved, we also cover the more proximal regions of that nerve of V1 to the base of the skull with the standard risk CTV. And we also will consider adding any nerve branches that connect to the same ganglion in that same CTV moderate dose. And then finally, we include the regional nodal stations on the ipsilateral side that are at risk, and we'll talk about the ones that we consider at risk. These are our dose fractionations for these levels of our CTV. Again, 66 gray to 70 for the high risk, and usually 50 to 56 depending on the fractionation style for the standard risk. For elective nodal radiation for patients with perineural invasion, the mid-face lesions, meaning that the lesions that involve the nose, the cheek, usually we cover the ipsilateral level 1B, 2, 3, and 4. For patients with tumors that primarily involve the ears, the temple, the preauricular region, the forehead, we often include the parotid space as well on that ipsilateral side. And for patients with tumors that involve the posterior scalp, we usually add on the occipital nodal stations just behind the occipital region here on the cranium to catch those nodes as well. These are the dose volume organ at risk constraints. This here for your records, just in case you're interested. And we just have a couple of cases and we'll finish up. And so this is a 65-year-old man with recurrent squamous cell carcinoma of the right forehead. He had previous surgery and the tumor recurred locally along the skin with invasion of V1, the ophthalmic nerve, the trigeminal nerve, all the way to the base of skull. This patient had his GTV drawn in red, And then the pink or fuchsia color you're seeing is the CTV, which added an extra margin along the skin surface and also an extra margin along the path of V1 to the cavernous sinus here. This patient also had a standard risk volume here in yellow, treating more of the skin, and then the entire length and width of the cavernous sinus, the Meckel's cave on the right, all the way to the trigeminals exit point from the brainstem at the pons. We also, in blue, can be seen here treating the ipsilateral nodal stations in right level 2 and in the parotid space. A second patient with a recurrent basal cell carcinoma with clinical perineural invasion of V2 on the right. V2 was grossly involved all the way to the cavernous sinus. You can see the GTV drawn here in red. The GTV extending along V2 along this path through the pterygopalatine fossa all the way to the cavernous sinus. You're seeing the blue intermediate risk treat that entire length of the path of the nerve as well. And then also the yellow standard risk here treating the entire length all the way to the cavernous sinus and its the trigeminal nerves, Meckel's cave, and its exit from the pons as well, although you can't see that specifically on these slices here. We treated this patient with PBS, and this is just capturing some of the isodose lines. We used 3 beams with PBS, the right superior posterior oblique, superior anterior oblique, and right anterior oblique. And we treated this patient in a similar fractionation style as the last patient. Total dose to the high risk volume was going to 70 gray and 35 fractions. And so in summary, we think proton therapy may help to improve the therapeutic ratio for patients with locally advanced dominant melanoma skin cancers. We think that dose escalation is safe using proton therapy, even when delivering concurrent chemotherapy. Alleged nodal radiation that we think is a part of this treatment because of the risk for subclinical disease among patients with perineural invasion, which has been published in previous studies. And we think when delivering protons, every effort should be made to deliver penicillin scanning with robust optimization and LET analysis, which we think should be the standard of care when delivering protons. Thank you very much.
Hello, everyone, and thank you for joining us. I'm pleased to be here today with my colleague, Dorothee Lebhertz, and together we will present the weekly hypofractionation proton therapy as a potential local treatment approach for high-risk head and neck non-melanoma skin cancers. So here is the agenda of today's presentation, but I would like to start with a clinical case of a patient treated in our department, which differ from those previously presented by Dr. Bryant. It's about a 71-year-old man in good general condition with a history of amyloidosis, which likely contributed to an immunosuppressed status and may explain the aggressive course of his disease. This patient, in 2013, he has diagnosed squamous cell carcinoma of the left nasal ala, confirmed by biopsy. He underwent a wide local excision with immediate reconstruction, followed by regular dermatological follow-up. The first local recurrence occurred in 2022. It involved the whole left nasal ala with deep invasion of the maxillary bone and the lacrimal pathways, but no distant metastasis. The patient underwent the extensive surgery, including heminasal resection and bone removal. Pathology showed a high-risk squamous cell carcinoma with lymphovascular and perineural invasion. No adjuvant treatment was given at that time, and multiple reconstructive procedures were required during the next year. 2 years later, a second local recurrence developed, this time on the right nasal wall. Biopsy confirmed the same squamous cell carcinoma, and the PET-CT imaging showed no evidence of distant metastasis. After a multidisciplinary discussion, future surgery or photon-based radiotherapy were ruled out, considering the technical limitation and the proximity of organ at risk in this area. Consequently, the patient has been treated with exclusive immunotherapy using a cemiplimab. Unfortunately, 6 months later, local progression was observed with enlargement of the right nasal lesion and the appearance of the second lesion extended toward the left orbit, while no distant metastases were detected. So, at that point, there were no other therapeutic option than local irradiation with curative intent. Therefore, several discussions were held with our medical physics team to choose between two possible treatment approaches, respectively photon-based radiotherapy using a bolus versus proton therapy using a redshifter. Photon radiotherapy was finally ruled out, considering the superficial target volume, the difficulties in manufacturing and positioning of a bolus in this anatomic area without any air gap, and of course, proximity of organ at risk, particularly in the left eye, which is the case here. So finally, the patient received exclusive proton therapy with concomitant immunotherapy with the aim of both improving tumor control and preventing distant metastasis. Therefore, cemiplimab was continued for 12 months in total. Thereafter, a follow-up evaluation confirmed the complete response. The clinical photograph and imaging shown here illustrate an excellent local regression of the tumor with a good cosmetic outcome at 8 months of follow-up. So patients like this are commonly seen in our departments as non-melanoma skin cancers are among the most frequent malignancies worldwide, with an estimated incidence of 7.7 million new cases each year. Indeed, this disease can be divided in low-risk and high-risk disease based on anatomical, clinical, and histological factors. High-risk disease is associated with larger or recurrent tumor located in the periorificial H-zone areas, and of course, aggressive histology with features such as deep or perineural invasion. As shown in the graph, prognosis worsen as these factors accumulate. Overall survival decreased from around 95% in patients with no risk factors to below 60% of patients when more than 4 high-risk features are present. So, considering all these arguments, we initiated a feasibility study to evaluate the efficacy and the toxicity of weekly hypofractionated proton therapy in patients with high-risk head and neck non-melanoma skin cancers. For that, first we defined 2 cohorts based on treatment intent, respectively cohort A for patients treated with adjuvant settings, and then cohort B for patients treated with curative intent. In both cohorts, treatment was delivered using 2 schedules in a stepwise approach. First of all, step 1, we used a moderately hypofractionated regimen of 3 gray per fraction delivered 3 times per week. And then step 2, a higher hypofractionated regimen of 6 gray per fraction delivered once per week. The main endpoints were local control, disease-free survival, and toxicity. Indeed, we include a patient with basal and squamous cell carcinoma located in the head and neck region, and each patient had at least 1 high-risk feature, including tumor size, deep and perineural invasion, regional lymph nodes involvement, recurrent disease, or immunosuppression. All included patients had an ECOG performance status inferior at 2. So a total of 138 patients were included, 87 in adjuvant cohort and 51 in curative cohort. There was a slight male predominance, while the patients treated in step 2 were significantly older and therefore more frail. In contrast, the 2 cohorts were well balanced in terms of histology, and notably with periorificial involvement in about 50% of cases in patients across all groups. The treatment planning was the same for all patients. The clinical target volume included a tumor or surgical bed, respectively, with 20 millimeters of margins. No bolus was used, and the 1 beams ballistics was favored in order to decrease the time of the session. The planning was done with the RayStation treatment planning system using robust optimization. And all treatment, all delivered using a Proteus-1 system with a range shifter in order to allow adequate dose delivery near the surface. We scheduled treatment session in 15 minutes for one beam and 20 minutes for two beams ballistics. Here are the efficacy results for the cohort A, corresponding to a patient treated with adjuvant settings. In total, 87 patients were included, 21 treated in step 1 and 65 in step 2. The median follow-up was 15 months. Overall, disease control was encouraging because no local recurrence was observed, including in patients with periorificial involvement. Regional control was also good, with only 6 regional nodal relapses and 1 case of distant metastasis. This corresponds to a disease control rate of approximately 95% at 6 months and 90% at 12 months. In terms of survival, only 1 patient died from skin cancer during the follow-up. And finally, the one-year local progression-free survival was 94% with similar outcomes observed in both treatment groups. Efficacy outcomes in cohort B, including patients treated with curative intent, was also quite satisfactory. 51 patients were included, 9 were treated in step 1 and 42 in step 2. The median follow-up was also 15 months. We observed a complete tumor response in 78% for patients treated in step 1 and 64% in step 2. There are 8 tumor recurrences, predominantly in step 2, and the regional control remained good with only 3 nodal relapses and no distant metastasis. This corresponds to an estimated disease control rate of 84% at 6 months and 72% at 12 months. In terms of survival, only 2 deaths related to skin cancer occurred during the follow-up. Finally, the 12 months local progression-free survival was 84%. Regarding the toxicity profile, most patients developed grade 1-2 dermatitis in 98% of cases, while the grade 3 dermatitis remained rare and exceptional. Concerning the late toxicity, grade 1-2 skin fibrosis and telangiectasia were observed in less than 20% of patients, with comparable rates between the 2 treatment steps. Importantly, several complications such as skin ulceration or flap necrosis were rare and remain exceptional, while the grade 3 keratitis occurred in 1 case. So, to better contextualize our results, we compared them with previously published studies. Indeed, in the adjuvant settings, Run and collaborators reported 5 years local control rate of 94% of patients treated with adjuvant proton-based radiotherapy. In our cohort, 87 patients treated with weekly hypo-fractionated proton therapy achieved one year local control rate of 100%, including patients with squamous cell carcinoma located in periorificial H-zone area of the head. In addition, for definitive photon-based radiotherapy in advanced cancers, most studies report a local control rate of approximately 50 to 60%. In our cohort, results were encouraging, with 1 year local control rate of 88% for basal cell carcinoma and 74% for squamous cell carcinoma. So, given the typically slow local progression of these cancers, an effective local treatment may improve not only quality of life, but also the overall survival. Proton therapy appears to be a safe and effective option, including for tumor located in periorificial H-zone areas of the head. Outcomes may be slightly improved in 3 gray par fraction regimen in fitter patients, as the 6 gray par fraction schedules are generally reserved for older and or less fit patients. Also, considering that the Proteus-1 redshifter allows a more accurate dose deposition at the surface, proton therapy may not require the bolus, thereby avoiding uncertainties related to the air gaps. In addition, the underlying healthy tissue can be better sparing, including in one beam settings, which is more cost-effective. Moreover, Weekly hypofractionations is often better tolerated in elderly patients and offers practical advantages for proton therapy centers, including shortened treatment times and easier scheduling. Overall, all these approaches may also reduce the total cost of the treatment. So, in conclusion, proton therapy is now well established in several indications, giving its superior ability to spare normal tissue. But in these specific settings, it may represent a particularly attractive local treatment approach in selected patients. These results indicate that high-risk skin cancers may constitute an emerging indication for proton therapy, of course, pending additional clinical evidence to clarify both the role of proton therapy and the weekly hypofractionation in non-melanoma skin cancers management, as well as future dosimetry validation. But for this, I will now invite Dorothee to outline the medical physics consideration.
Thank you, Dinu. So, encouraged by the promising result of proton therapy for skin cancer, Dr. Stefan asked us if there was a physical explanation that would prove the benefit of using protons. So we are trying to find physical evidence. With photon therapy, we use bolus, which may introduce air gap and cause skin underdosing as reported in the literature. In contrast, we delivered proton PBS without bolus, suggesting a potentially more effective skin dose, possibly enhanced by proton-specific effects. We present this clinical case at PTCOG 2023. This patient was treated with VMAT in 21 fraction with DD-CBCT and he relapsed. We observed on the CBCT the formation of an air gap up to 1.2 centimeters. Then the initial VMAT plan was therefore recomputed for each daily fraction, and in parallel, a virtual equivalent proton plan without bolus was also computed. These figures show the dose distribution received by 98% of the CTV for each fractions and modalities. Even if the distribution is slightly narrower for protons, in both cases, 98% of the CTV received at least 95% of the prescribed dose for all fractions, indicating no major impact, even for photons. This raised the question of whether the TPS properly accounts for air gaps. More importantly, instead of focusing on the entire CTV, we may need to specifically look at what happens at the skin level, meaning in the first 3 mm. We therefore decide to focus on the first 3 mm of skin. Currently, there is no detector capable of accurately measuring dose at depths below 100 micrometers. Our goal is to develop detectors specifically designed for this purpose. To do so, we established collaboration with French research laboratories, obtained a PhD scholarship for Julia Tosetti, and got MITI funding to develop both a photon and a proton detector. To measure photon or electron dose at surface in the presence of an air gap, we needed a detector with a linear response and with a sensitive volume located at depths below 100 micrometers to probe the skin and behave to measure dose in region without electronic equilibrium. This requires a water equivalent material. We therefore designed a detector based on a 4x4 square centimeter plastic scintillator sheet coupled with wavelength shifting fibers and with the signal transported outside the treatment room using optical fibers. For this experiment, the detector was placed 1 meter from the source directly at the surface. A 1 centimeter water equivalent bolus was then moved to vary the air gap. On the graphic, on the x-axis, we show the air gap thickness, and on the y-axis, the measured dose normalized to the dose without an air gap. Each point corresponds to different field size, while the dashed line represents the average dose calculated by the TPS in same condition. As expected, for both measurement and TPS calculation, the dose difference increases with the air gap, and the effect becomes stronger as the field size decreases. However, this effect is systematically less pronounced in the TPS. For example, for a 1 centimeter air gap and a 10 by 10 field, the red curve, the TPS predicts about 2% dose loss, whereas we measure around 5% with our detectors. We repeated the same air gap measurement by lowering the detector from the surface to depth of 3 millimeters. You have the result for the different depths, and here I show the result obtained for a 10 by 10 field and a 1 centimeter air gap as a function of depth. The dose difference clearly decreases as we move deeper into the skin. As expected, the influence of the air gap becomes progressively less significant with depth. As shown in these two dose distributions with and without an air gap, the impact of the air gap is stronger at the edge of the beam. When using a 4 by 4 square centimeter scintillator, this effect is amplified, and the detector positioning becomes critical. This is why in the final detector design, we will reduce the scintillator size. Regarding the proton detector, we have just received the funding and the development has recently started. The detector must provide a linear response to dose independently of the proton energy with a sensitive region located at depth below 100 micrometers. Because of the pulse delivery in proton PBS, a response time shorter than 100 microseconds is required to separate individual pulses and access dose rate information. Finally, the detector must be able to retrieve the spatial distribution of the dose to enable a 2D measurement. To achieve this, we combine an integral ionization chamber for accurate dose measurement with a strip ionization chamber to obtain spatial information, and all coupled to ultra-fast electronics. In conclusion, we developed a new detector capable of accurately measuring skin dose at depths below 100 micrometers, even in regions without electronic equilibrium. Using this detector, we showed that air gap of 1 centimeter can lead to surface dose reduction exceeding 5% for field below 10 by 10 square centimeter, while it rapidly vanishes within the first 2 millimeters below the surface. Ongoing work will focus on finalizing and characterizing a 2 by 2 square centimeter version of the detector and repeating the measurement. In parallel, we are starting the development of a dedicated proton PBS detector with future studies focusing on spatiotemporal skin dose measurement in the first few millimeters. Thanks to the measurement campaign we will be conducting, as well as the phase 2 trial obtained by Dr. Stefan, we hope to be able to determine soon whether the use of proton offers an advantage for skin cancer. We would like to thank our colleagues for the support into studies from the clinical and research teams, and thanks a lot for your attention today. If you have any questions, please let us know, and we hope to see you at PTCOG Congress and Cyclhad Center visit for further discussion in June this year.
Thank you to all three of our presenters for the excellent presentations. The floor is now open for questions. Please put them in the chat, and I will invite our speakers to answer them as they arise. Thank you.
We have already one question in the chat. I can read it. With the increasing use of immunotherapy for recurrent cutaneous SCC, including cases with perineural invasion, how has this changed your sequences of local therapy? Specifically, medical oncologists are increasingly advocating for immunotherapy with ctDNA surveillance and deferral or omission of radiation based on response and durability. In cases of clinical PNI, how do you view this approach, and what level of response or duration will make you comfortable delaying or foregoing RT?
Indeed, the immunotherapy, it's a very interesting option, and personally, I like to associate with proton therapy in selected cases. In the studies with neoadjuvant immunotherapy, we had complete response in 40% of cases, I think, and we think that our results it's slightly superior of that. And the most important is that hypo-fractionated proton therapy is cheaper comparing with immunotherapy, I think, and maybe they are less side effect So the proton therapy, maybe it can be administered even for the patient which is not fit. But it's be very interesting to compare directly the hypofractionated proton therapy with the immunotherapy, which is we plan to do it in the future.
I agree. I think that we still favor the delivery of radiation. We do think that there's a role for the combination of immunotherapy and radiation, but we don't think that by itself immunotherapy has shown enough long-term success for management of this condition.
Well, I'd like to thank everyone who attended this session. I think we're all excited about the tool that we have in proton therapy for tackling these difficult tumors, and we're excited about the advances to make these treatments more accurate. So I'd like to thank the speakers and all the attendants, and we'll give you back a few minutes for your busy day. Thank you so much.
Thank you.
Thank you.